Hi everyone, very good afternoon and welcome to the next session, that is the post-prandial boost. I hope all of you are able to hear me. I hope I'm audible and visible. So this is an ongoing series, as all of you know, 2 p.m. on the YouTube channel, and today we are here with the third day of the same. The previous two PDFs, I've already posted them on the Telegram group. So in case you've missed out on the previous two lessons, they are available for you to view on the channel and you can pick up the notes from the Telegram group. Before I proceed, just letting you know about few batches that have started for the FMG students and for the NEET PG students on the platform since yesterday itself, which are a 6 monthly and 3 monthly batch respectively. Also, there is going to be, if you ask me in terms of pathology for the FMG students, there is a separate pathology batch that is going to be conducted in the month of February for a total of 44 hours, and that will be enough, more than enough, for your upcoming exam. So in case you're targeting the June FMG paper, then this is the batch that can help you. So this is basically coming under the plus subscription, where you'll also get access to all the classes, apart from that the QBank and all the tests and quizzes that are going on the app. So having said that, before we begin, festive day, 13th of January. So happy, yes, thank you Dr. Satvik and others. Happy Lodi to all of you as well. So keeping the festivities in mind, we'll keep it as a short session and we'll discuss 5 quick questions that we have. The first question that I've brought today is actually a question which is in continuation with one of the doubts that the students had asked me yesterday. So let's pick it up from there. Let's begin with question number 1. So read the question and then we'll discuss whatever needs to be discussed over here. So 52-year-old man presents to the office for evaluation of a weird rash that appeared over his torso last week. The patient states that the rash just seemed to appear but denies any itching pain on exposure. Now, on physical examination, there are multiple light brown colored flat macules on the torso, and they appear to be stuck on but do not have any associated erythema or swelling. What is the most likely indication of the patient's clinical presentation? Yes, Dr. Sahiti, somewhere I had answered this yesterday also, but I couldn't connect with you. I think by that time the class was over. But keeping that doubt of yours in mind only is exactly why this question has been brought up today. So, first and foremost, if you have no idea about what is happening, which derma condition is being spoken about over here, if I delete everything from this, but I just look at one word, whenever the word stuck on lesions has been used in dermatology, it is used for Siboric Keratosis. Now, first and foremost, I'll show you the clinical and histopath also, but Siboric Keratosis is something that has a stuck on manifestation. Let me show you a picture first. So, over here, if you look at the exact how the patient came to you, the patient had this rash like condition on the torso. So very commonly the trunk and the torso are what are affected, and if this is, for example, the level of the skin, this lesion will always be as if it is stuck onto the skin. So you can see these multiple lesions as if you've put something on top of the surface of the skin. So these will be multiple stuck on kind of lesions. The word stuck on always goes hand in hand for Syboric keratosis. Now, coming to what Dr. Sahiti had asked us yesterday also, and what we had summarized right in the end, that multiple seborrheic keratosis, like this patient has multiple lesions with stuck-on appearance, that is associated with mutation in FGFR3. There are other things also with FGFR3, which we will be talking about, but this is associated with mutation in FGFR3, point number 1. Point number 2, it is also associated with lesser Trallet sign. And that was the answer to the question over here. See, over here they've not asked you the genetics, so that is ruled out. They have said that there has been a sudden onset. The patient is saying that this has just seemed to appear and he has no other symptom that he's suffering from. Suddenly he has these multiple seborrheic keratosis, and that is highly indicative of an internal malignancy. Internal malignancy, by internal malignancy I mean some kind of visceral malignancy. Two very common visceral cancers that you are seeing over here are going to be colon cancer and stomach cancer. cancer. These two cancers are very, very common. So if someone comes to you with sudden onset of multiple seborrheic keratosis, like this patient, sudden onset multiple seborrheic keratosis, this is known as lesser Trallet sign, that you will start suspecting that he has some carcinoma of the GIT, maybe a colon cancer or a stomach cancer. So what is this sign known as? Exactly what this question was. This question was a case of lesser Trallet sign. It's a very important question in dermat, also in pathology. And then if you go a little bit more into lesser Trallet sign and you ask me, ma'am, what is the pathogenesis? How is seborrheic keratosis associated with cancers? Is there any mediator? Yes. They are saying that this is because of production of TGF alpha by the malignant cells. TGF alpha by the malignant cells. Did I teach you TGF alpha somewhere yesterday also? So again, yesterday and today I've tried to link a few things so that as a whole you get an approach to it. Did I teach you somewhere about TGF alpha, all those TGF, TNF we did yesterday, right? Yes, very good. TGF alpha was something always to do with gastric. So I stand by the mnemonic right now also. TGF alpha, gastric का कौन सा disease था? It is associated with Menetrier's disease. And now also I'm telling you the same thing. I'm saying you have a patient of gastric cancer, you have a patient of GA, that is gastric cancer, and if these gastric cancer cells, if they produce TGF alpha, which dermatological condition can the patient land up with? The patient can land up with Siboric Keratosis. I hope the entire concept is clear. So GA will always remind you of something to do with gastric. Now coming back, the only thing that we are left with is the histopath. Very clearly you've said stuck on lesion. Means if this is the skin, the lesion will be stuck on. Exactly what you see on histopath also. That if this is the normal skin, if you see the lesion, if this was the surface of the normal skin that we have, this lesion is like a stuck on thing. So I think the stuck on word will help you clinically, the stuck on word will help you in pathology also. And as you zoom into this, let me see a zoomed in picture of this into this stuck on lesion. Can you see there are these cysts that are present, round cysts which are filled with pinkish material. So there are these round cysts and they are filled with pinkish flakes. What do you think is this? At the end of the day, this is skin, right? This is epidermis. Skin hai, epidermis hai, means it's going to have keratin like every other skin. So these are nothing but lots and lots of keratin flakes inside, and these are referred to as horn cysts. These cysts are referred to as horn cysts because what do they contain? They contain a lot of keratin. So putting everything about seborrheic keratosis under one place, they are very commonly seen on the trunk. They can either show me mutations of FGFR3 or they can be associated with lesser Trallet sign. Lesser Trallet sign is some kind of cancer of the GI tract, stomach cancer. So TGF alpha is a good mediator that you have over here. Apart from that, it is also going to show you the stuck on appearance when it comes to the histopath, and that was the question that you had over here. Now, going a little ahead of that, one more thing that you will tell me with FGFR3. Let's just finish that off. When I say FGFR3 mutations are noted, why not you complete the list for me? The first list I've told you is seborrheic keratosis. Anything from orthopedics that you want to tell me apart from seborrheic keratosis? So you must have seen that even cases of achondroplasia, this is very good, exactly what we were discussing yesterday. Achondroplasia also shows you the FGFR3 mutation, and amazing again what we discussed yesterday, thanatophoric dysplasia. Yes, thanatophoric dysplasia. So I think Dr. Sahiti, this is what you were asking me yesterday, that what are all the different FGFR3 mutation lists that I have, and this is what you have to go in for. Okay, having done with this question, let's move on to the next question, guys. Question number 2 for the day, and here you go. So let's read it together only. You have an 8-year-old boy who presents to the emergency room with a 3-day history of fever of 102 degree Fahrenheit and abdominal pain. He complains of pain in his right knee, so abdominal pain hai, pain in the right knee is there, elbow is there, so multiple joint pains are there somewhere. He was seen 4 weeks ago because of sore throat and a rash. So 4 weeks ago he had a sore throat, and obviously a throat culture was performed which showed gram-positive cocci in chains. Because there was bacteria, antibiotics were given. Um, uh, all of that continued. Now when he's come to you on physical examination, temperature is 101, heart rate is 96, BP 100/60. Cardiac examination shows a murmur which is felt or heard at the apex. Now his right elbow is tender on extension because of all the arthralgia that he's having. Lab investigation shows positive or elevated C-reactive protein, WBC of 22,000 with a shift to left, and ECG shows you prolonged PR interval. Okay, so a lot of very good. I think the question per se is whatever possible information that they could have given, they've given it to you. I don't think they've even kept 1% of the clinical thing hidden, and that is always an advantage that a lengthy question has. No matter how much are we scared of lengthy questions, but somewhere while making a lengthy question, examiner gives more than what he's wanting to. So everywhere over here, yes, it's shouting out to be a case of rheumatic fever. It's literally shouting out every little thing, be it prolonged PR interval or C-reactive protein, gram-positive cocci in chain. So which organism? In chain. So I think this is exactly what they're trying to tell you, gram positive, because it's purple, so it's definitely gram positive. And definitely they are round organisms, so they are cocci. Again, the second word also makes sense. And how are they arranged? They are arranged in a chain, and this is a classical description of Streptococcus pyogenes. So I know Streptococcus pyogenes definitely causes rheumatic fever, and that is what was given over here. Now you have to find out that this microorganism, you have to analyze it with the help of the tests that have been given. So I think many of you have got it right. So let's read more about Streptococcus. Answer to sabko pata hai, you know what the answer is. So let me read more about it and we'll come to the answer. So first and foremost, Streptococcus pyogenes will be a gram-positive cocci that you will see in the chain formation, in the chains. Well done. This is okay. Coming to the next, what does it show on a blood agar? Over here, the reddish color medium that I have grown, it is a blood agar. The culture media is a blood agar. And I saw that again, everywhere it is Streptococcus pyogenes. So it has a tiny colony over here. So I can say it is a pinpoint colony over here, number one. And surrounding that pinpoint colony, there is a wide zone of hemolysis. Yes, there is a very wide zone. So this much of zone around it, this much of zone around it, there is a wide zone of hemolysis. I think everyone remembers our mnemonic that we always used to study, right? That when we are dealing with pyogenes का सब कुछ पाए होने वाला है. So for example, I say that this was the patient who came to you. This was that 8-year-old child. You had to collect a throat swab because he was having sore throat, or you had to collect the blood culture. Anything that you have to culture for Streptococcus pyogenes. What is the transport media in which you will place the sample? So what is the transport media? That is also with a pi. So remember, for pyogenes, the transport media of the sample will be the Pike's medium. Very good. The transport medium is Pike's medium. So the first thing for pyogenes, it's Pike's medium. Next, when it comes to the blood agar, for pyogenes, it is pinpoint, so pine point or pinpoint colonies. And what kind of hemolysis? Narrow zone or wide zone? Wide zone of hemolysis. So we always remember for pyogenes, it is pi, y. This means Pikes is the medium, pine point or pinpoint colonies, and wide zone of hemolysis. Now let's come to what other culture media. If I ask you what is the selective media that you had to grow it on, again you will learn it by the word pyogenes. See the way you write pyo, P will be the PNF medium. One selective medium is the PNF medium. Then the Y, I am going to change it like this, violet. Crystal violet blood agar, not regular blood agar, the crystal violet blood agar. And third one, it tends to show you a lot of granularity. So on liquid medias, it tends to show you granular turbidity. So repeating with me, the first selective media for pyogenes is the PNF medium. The second one is crystal violet blood agar. And the third one is going to show you granularity on a liquid medium. So your selective media are also learnt by the word pyo. What are you left with? The different kind of biochemical tests. So firstly, there's the first distinguishing feature that I do in bacteriology is always between staph versus strepto. These are the first two chapters of bacteriology, right? Staph and strepto. I think one thing that I don't have to give you a mnemonic for, everyone knows that staphylococcus is catalase positive and streptococcus is catalase negative. So streptococcus is catalase negative. I really don't think we need a mnemonic for that. That's a well-known universal fact. What are the other tests that you need to know about? Again, the way you write streptococcus pyogenes, if someone asks you what is the status of bacitracin, is it sensitive or is it resistant? So remember, streptococcus pyogenes is bacitracin sensitive. And what is the status of the PYR test? Remember, the PYR test is positive. Again, from the word streptococcus comes everything. Remember, it is bacitracin sensitive and it is PYR test positive. So let's do a very rapid recall of this. I'll just write streptococcus pyogenes and everything comes. If I ask you the transport media, Pike's media. Blood agar, what colonies? Pinpoint colonies. How much of hemolysis? Wide zone hemolysis. What are the selective media? Selective media, P for the, I think everyone knows the PNF, very good. Then Y का V बनाएंगे, so crystal violet blood agar, and then O से you are going to get turbidity on a liquid medium. Coming to the biochemical test, bacitracin sensitive, and coming to the PYR test positive. So that is an entire nutshell of everything about streptococcus pyogenes. Coming back to rheumatic fever, coming back to this, I think the only test that is fitting over here which you had to select was sensitivity to bacitracin. So I hope that is okay with everyone. Dr. Sahiti, rheumatic fever and PSG, and if you ask me, are they caused by streptococcus pyogenes? Yes, both of them are caused by streptococcus pyogenes, but for as far as PSGN is concerned, the usual strains are usually streptococcus pyogenes 12, 4 and 1. These are the usual ones, although you don't have to learn all the numbers and all. But for streptococcus pyogenes causing PSGN, post-streptococcal glomerulonephritis, strain number 12, 4 and 1 is very, very famous. Okay, so having said that, now let's move forward. Moving on to question number 3 of the day. 5 questions, and here we are on question 3. Again, let's read it together, then you will tell me the answer. So there's a 20-year-old male patient who presents with multiple cervical lymph nodes ranging in size from 1 centimeter to 3 centimeters. The largest lymph node is aspirated. When they say aspirated, they are wanting to tell you that an FNAC has been done. So which lymph node? The 3 centimeter wala lymph node, FNAC was performed. It shows the presence of binucleated cells with inclusion like nucleolus. On IHC, the ball and chain pattern of CD30 is noted. Which of the following statements is incorrect about this tumor? So I've got 6 or 7 answers over here already, more pouring in, and all of them unanimously happen to be the same. So one thing is there. Sometimes the options are given in accordance to the question. Sometimes even if you've not read or understood much of the questions, and still if you read the options, you might end up picking up something which is grossly incorrect. And this is one of those questions. Question kuch bhi chal raha ho, when I started reading the options, there was one option that I read where it said interleukin 12 is responsible for eosinophil activation. Forget whether I'm talking about this is a case of Hodgkin's, forget Hodgkin's or non-Hodgkin's. That is out of the question here, because whenever I'm talking about eosinophil activation, I know E is the fifth alphabet. E is the fifth alphabet, and always it is interleukin 5 that helps me with eosinophil activation anywhere in the body, whether it is allergies or parasitic infections or Hodgkin's lymphoma. eosinophil है तो it has to be interleukin 5. So even without the question, I know that this statement is the wrong answer. But still, we'll read the question once again. So over here, you clearly had, what is this description written? Binucleated cells with inclusion-like nucleolus. Are they talking about the RS cells? That is what, see, binucleated, as you can see, binucleated cells or mirror image nuclei with inclusion-like nucleolus. That is what gives it the owl-eye appearance. So that is the owl-eye appearance. What did they read next? Next, they wrote, on IHC, immunohistochemistry, ball and chain pattern of CD30 is noted. So first question for you is, what are the markers of the RS cells that you have to know? RS cells have 3 markers which are written over here, which was a true statement. RS cell is CD15 positive, RS cell is CD30 positive, and it is PAX5 positive. 15, 30 and PAX5 positive, out of which, remember, if someone asks you which is the most sensitive marker, so remember 15, 30 and PAX5. So CD30 is the most sensitive marker and PAX5 happens to be the most specific marker. These are again 2 very important questions for RS cells. 30 is the sensitive one, PAX5 is the specific one. Now, what is this technique shown over here to you? This brown color cells. The brown color technique is always immunohistochemistry. The brown color technique is immunohistochemistry, and especially for CD30, I'll draw it out and explain it first. When they saw, for example, if this is an RS cell and this is the, the owl-eye appearance that it's showing, for CD30, they found something very unusual. They found there was one brown color here and then there was brown color around the membrane, around. So you know what they called it? They called it ball and chain pattern. I'll draw it again for you. See, they said you are getting a brown color dot inside the cell. That is referred to as the ball. And then they saw that like a chain, there was a brown color that you were seeing around the cell. So then they ended up calling this as the ball and chain pattern. So CD30 particularly shows you the ball and chain pattern on immunohistochemistry, and that is what was mentioned over here, ball and chain pattern. Now you had to tell me which of the following statements is incorrect. Okay, so what all is mentioned over here when I'm talking about these classical RS cells? Tell me, classical RS cells are seen in which kind of Hodgkin's lymphoma? The nodular sclerosis or the mixed cellularity or lymphocyte depleted, lymphocyte rich? Which variety most commonly shows me this classical variety of RS cells? All of you will agree that mixed cellularity shows me this classical variety. So is mixed cellularity the most common type seen in India? Yes. So some one-liners that we are going to do. If I would have asked you which is the most common type of Hodgkin's lymphoma worldwide, then your answer would have been different, and most common Hodgkin's in India is different. So in the worldwide, it is nodular sclerosis, whereas in India, remember, it is mixed cellularity. So this statement was right. So MI will say this is the most common in India. Most common in India is going to be mixed cellularity. Now when I say mixed cellularity, you will say, ma'am, the word is only telling us that it's going to have a lot of cells. Means it's going to have that RS cell, it's going to have lymphocytes, it is going to have eosinophils, it is going to have plasma cells, it's going to have a whole spectrum of cells. Fine. So if I ask you who has got the eosinophils, which interleukin has got the eosinophils in this, I think all of you know by now. Interleukin 5 gets the eosinophils over here. So clearly that was the wrong statement. My last question, and listen to this like with full concentration and be maximally alert. If I ask you what kind of a lymphoma is Hodgkin's lymphoma, if I ask you the cell of origin, is it a B cell or a T cell? The cell of origin of Hodgkin's lymphoma. It's a question that came in the NEET PG exam. It's a B cell. Hodgkin's lymphoma is a B cell lymphoma. And to be very, very precise, the cell of origin is a post-germinal center B cell. That's the exact word that you have to know. The cell of origin is the post-germinal center B cell. That is what most commonly Hodgkin's lymphoma arises from. So indirectly, if I ask you, what is the origin of the RS cells? You will say RS cells are seen in Hodgkin's lymphoma. So RS cells are arising from post-germinal center B cells. So I'll draw lots of RS cells over here. These are all RS cells and their origin is the post-germinal center B cells. But I'm also talking about some lymphocytes which I'm saying are scattered in the background. These lymphocytes, there are some which are scattered in the background. What are these lymphocytes? These are the T lymphocytes. So that is what they had told you. The background shows presence of T lymphocytes is a true statement. It's a true statement. If they would have said the RS cells are derived from T cells, that would have been wrong. The origin is always the B cell, but the background lymphocyte, these lymphocytes in the background, they are of the T type. I hope there should not be any confusion going forward and you are sorted with whatever information that had to be given over here. So just a quick recap. Yes, it is CD1530 positive, true statement. Yes, the background shows presence of T lymphocytes, true statements. Yes, the subtype is most common in India. The only wrong statement was interleukin 12 for eosinophils, which is it is interleukin 5. Dr. Mehek has a query. Germinal B cell. Kya query exactly? I did not understand. Germinal B cells ka what exactly is your query? Post germinal, see, you know, right? This much you know that a lymph node hota hai. It has a lymphoid follicle and the center of the lymphoid follicle is the germinal center. So when I say post germinal center, I mean the B cell has made its journey through the germinal center. After getting exposed and coming out of the germinal center, that is the kind of B cell that is giving rise to Hodgkin's lymphoma. That is exactly what I wanted to put up over here. I hope there's no other query and it's sorted. So let's move on to the next question. And here you go. There's a skin biopsy from a patient which reveals the following features. So it's an entirely image-based question. There is practically no hint that the theory or the question is giving me. Either you analyze the image or you don't. There's no other way out. So skin biopsy of a patient reveals the following features. Okay, I think many of you got it right. And that is Langerhans cell histiocytosis. Let me zoom into this picture first, then I'll rule out all the other options. So when I zoomed into this picture, I could see two things which was very prominent. One, I could see a cell. I could see a cell with this groove inside it. So I could see a coffee bean appearance. I could see a coffee bean nucleus. Point number one, coffee bean nucleus. Other than that, I could see some orange looking cells. These are all orange looking cells. I know that the inflammatory cell, which is always and always orange in color, that is an eosinophil. So number one, I see coffee bean cells. Number two, I see eosinophils. And they have asked me that some skin involvement has occurred. This is a classical finding of Langerhans cell histiocytosis. What about the other options? Why can't it be just a dermatitis? Firstly, dermatitis is such a vague thing. They've not told me which type of dermatitis. They've not told me anything about it. And when I'm just saying dermatitis, itis is just inflammation. So inflammation would not specifically only show me eosinophils that I'm seeing over here. It could show me neutrophils. It could show me lymphocytes. So that's a very vague thing to write. I cannot give a dermatitis just on the basis of one picture. Next, they said metastatic Crohn's disease. Crohn's disease, everyone knows, is an intestinal disorder. It's an IBD, inflammatory bowel disease, and microscopically shows you what? It's very famous for showing you non-caseating granulomas. It's very, very famous for showing you non-caseating granulomas. So if the same intestine disorder happens in the skin will also show you the same non-caseating granulomas. So over here, I'm not seeing any granuloma. So I can clearly say that this is not a case of Crohn's which is showing skin manifestations. Not happening. Coming to the first option, mastocytosis. First and foremost, mastocytosis is not a diagnosis that you can make as a spotter over here. And neither can you make it without any special stains. What special stains for mast cells do you all know of? Is there any special stain for mast cell which I've always taught you? So for this is the same special stain which you can use for basophils also, and you can use this stain for mast cells also, and that is a very good, that is a toluidine blue. The special stain that you will have to use to prove that there are lots of mast cells. Only a regular pink and blue cannot come to a conclusion for mastocytosis. You'll have to give a special stain of tall blue, prove that they are mast cells, and then proceed forward. And secondly, the genetics also has a major role to play. Anyone who remembers that what is the genetic alteration in mastocytosis, which should have been mentioned in the question. So I think you all know c-KIT or CD117 mutation is very, very famous for mastocytosis. c-KIT or CD117 mutation. So I think now that you've analyzed this much, तो mastocytosis ये नहीं था, tall blue was not mentioned, CD117 was not mentioned, it's ruled out. But still, if I ask you all the things which CD117 will come in your path always in pathology. You will have to learn this. There is no escaping this. CD117 or c-KIT mutations will be seen in the Games tumor, and we have to know each and everything. Don't miss out on even one tumor for c-KIT or CD117 mutation. So I think mnemonic sabko pata hai that whenever you go to play games, you carry a kit. So KIT is for games, but full form you have to know. G stands for gastrointestinal stromal tumor, that shows you CD117 mutation. AM, if you read it like this and they ask you which leukemia, you will say AML. Then first read it as AM, so you got AML. Now read it ulta, MA, so you will get mastocytosis. When you read it as MA, you will get mastocytosis. Let's move forward. Again, now go on to the next two alphabets. ME, melanoma. Melanoma shows you CD117 mutation. Now going to the last one, read opposite. SE, seminoma shows you CD117 mutation. And if I've written seminoma, then but obvious the ovarian counterpart also they always go hand in hand. So the ovarian counterpart, that is dysgerminoma, also can be written over here. So remember, G for gist, AM for AML, MA for mastocytosis, ME for melanoma, and SE for seminoma and dysgerminoma. All of these will come in your way when you deal with c-KIT or CD117. So now that I've ruled out everything, my clear-cut winner over here is Langerhans cell histiocytosis. And if I ask you that which of the following immunohistochemical markers could you have used for the confirmation over here, the same case that we had, and which of the following markers? We are still continuing with question 4, just one or two more on the question 4 only. Immunohistochemical markers for LCH, for Langerhans cell histiocytosis. Yes, this is more of a learning question rather than attempting. I want you to learn all the markers of immunohistochemistry for LCH. So first, there are two CD markers. There is CD1A and CD207. CD207 is also known as Langerin. And it's easy to learn, na? Langerhans cell histiocytosis. So the name of the marker is Langerin. CD1A, CD207. Other than that, S100 and HLA-DR. These are the 4 markers that you will have to learn for LCH. Repeating, CD1A, CD207, S100 and HLA-DR. But is this the gold standard? For the diagnosis of the lesion of Langerhans cell histiocytosis, is immunohistochemistry the gold standard? Is light microscopy, fluorescent microscopy, electron and phase contrast? The gold standard is not this. This is a very good technique. The immunohistochemistry, microscopy, very good technique, but the gold standard always remains as electron microscopy. And I think everyone knows what is the classical appearance that you see on electron microscopy. It's the tennis racket appearance. So tennis racket appearance on electron microscopy is the gold standard till date, with which you are almost done with it. Now that we are finishing this topic off, why not you tell me the mutation also that you see in Langerhans cell histiocytosis, and then we are fully done. Then the topic is only over. LCH shows you the very, very classical BRAF gene mutations. BRAF V600E mutation. BRAF V600E mutation is seen in LCH. So I think this is something you already know. This was just a quick recap. Okay, having said this, we are left with one more question, and this is more of a numerical. Again, someone was asking me such a question over Telegram a few days back, and that's the reason that we are discussing it over here. So let's read. Punjabi couple presents to you fearing their child may have thalassemia because both their families do have a history of thalassemia that is there. Now, if they have a history of thalassemia, you will order the patients to undergo HPLC. So HPLC has been done for both husband and wife, and their HbA2 levels are 2% for the husband, 4.9% for the wife, HbA2 levels, and what percentage chance of their child is likely to get thalassemia major. So, okay, you say both aren't carriers. Are you sure? Are you sure both aren't carriers? So first and foremost, there are two scenarios over here. We are talking, we'll work it out. We are talking about beta thalassemia, and there are two situations. Either someone could be suffering from thalassemia major, or someone could be suffering from thalassemia minor, and that we also refer to as a trait individual trait, or you can also call that person a carrier. Now, the gold standard whenever, not just thalassemia, any hemoglobinopathy, beta thalassemia, alpha thalassemia, sickle cell anemia. If you ask me that for any kind of hemoglobinopathy, what is the kind of investigation that you order? We always order an HPLC. We always order HPLC. See, thalassemia major is always easy to pick up because this is the patient which always shows you symptoms. Starting from childhood only, this patient will be dependent on blood transfusions, will always be visiting the doctor repeatedly. So this patient cannot go hidden. But this thalassemia minor patient can definitely go hidden. Why? Because this could be a carrier state. And all of us know that thalassemia is an autosomal recessive condition. Means the genotype of the patient could be this capital A small a. I'm just taking a random gene A. So capital A small a, and the small a is what is carrying that particular defect. But it's a recessive one and it cannot show expression. So that is why this patient is referred to as a carrier or as a trait. So how do I, symptoms to nahi hai. This patient is definitely asymptomatic. So how do I pick up such a patient? On doing HPLC technique, the HbA2 levels come out to be more than 3.5%, and that is when I get a confirmation that someone has thalassemia trait. When HbA2 levels are more than 3.5%. Let me come back to my question. Over here, the husband is HbA2 levels, my cutoff 3.5% से ज़्यादा मतलब problem है. So the husband is not having thalassemia trait. Husband is 2%, but look at the wife, 4.9%. So can I say the male person over here is totally normal, but the female and the wife over here is a case of thalassemia trait, and that is the reason that they are coming up for this testing. Now tell me, if one is totally normal and one ends up being a thalassemia trait, what are the chances of the child being thalassemia major? When will someone be thalassemia major? When someone is small a, small a. Both the alleles are small a, that is when the person will be thalassemia major. Someone says 25%. No, there is no chance. If one of them is a trait and one of them is totally normal, there is no chance of the child having thalassemia major. Let's do that 2 by 2 analysis. I think that will give you more clarity. So for example, I am saying this is the husband is totally normal. This is the wife, and the wife has this small allele which is defective. So do your 2 by 2 analysis. Capital A, one child. What is this child? If this child is born, this child will be totally normal. Okay, next, capital A, small a. What would this child be? This child is born as thal trait, means this child is born as a carrier, or thalassemia minor, thalassemia trait. Okay, let's go on to the next. Capital A, again a normal child. And next one that we see is capital A and small a, and that is again a thalassemia trait. So was anyone born as a thalassemia major? For those who had any confusion, there is no thalassemia major. So 0% people will be born with a thal major. How many, if I ask you, how many would be born as thal traits? 50% of them have a possibility of being born as thal trait or as carriers. So when will a child have chances of having thalassemia major? If, for example, the husband also would have been a trait and the wife also would have been a trait, then yes, then there was a possibility that one of the child being born ends up with thalassemia major. So, for example, now if I change the question, now, yes, Dr. Samina, this is exactly what you had asked. What if both the parents would have been carriers? Then, yes, there is a that is why they say that it is important to do HPLC testing. If one of the parents turns out to, so say for example, see, usually when a female comes during her first trimester of pregnancy, we only do her blood tests, right? But if a female is diagnosed as a thalassemia trait, it's very important that you counsel her and you tell her that get your husband also for a blood test. Look at his blood test analysis also, because अगर husband normal है then तो it's okay, the child can at the max be this situation, at the max the child can be a thalassemia trait, the child will not be a major. But if by chance unfortunately the husband also turns out to be a trait, then you have to counsel them for their pregnancy, because there is a 1 in 4 chance of the child being born as a thalassemia major. So then yes, 25% chance is definitely there. So if I would have given you a question like this, where I would have said husband's HbA2 levels are also 4.5 and wife is also 4.9, means if I would have labeled both of them as carriers, then you would have said that yes, there is a chance of 25% that the child can have thalassemia major. But over here I clearly told you husband is normal and only wife is the trait. So how will you analyze these questions? You should just know that the HbA2 cutoff is a 3.5%, which I need to learn for thalassemia minor, which finishes off our discussion for the day, and we can wrap up the session, I suppose. So we are going to meet tomorrow as well. Today unfortunately we couldn't have a kickstart morning session, so we bring it up from there itself tomorrow. Tomorrow morning 7:30 the kickstart morning stays as it is, and then in the afternoon at 2 p.m. we continue with this YouTube session that we are having. So hoping to see you all tomorrow as well. Yes, thank you so much for joining in. Have a great day, and see you all tomorrow morning. Thanks.